Well, Ian, thanks. Thanks for asking me to talk on paragangliomas. My favourite topic, because from the moment the patient walks in, you feel sort of uncomfortable because they tend to come in feeling anxious, as most people do with tumours, and they say, "Doc, is it cancer?" And with paragangliomas, in general, the answer is no, but it's not really the kind of definitive no that they're looking for, because obviously paragangliomas can metastasize, but it's extremely rare. So from the moment the consultation begins, the whole thing is slightly less comfortable than one might have hoped. And I guess some people like that and some people don't. Okay, sorry, just strangely not moving on slide as oh, there we go. Okay, so what we're going to do, talk a little bit about paragangliomas in general, a little bit about how we'd work up a patient with a temporal bone paraganglioma, how you make a decision what to do, and then a very little bit about what you actually do if you're doing an operation. So quite a lot to try and fit in, so we'll sort of skip through. Happy to answer questions. My first question would be, why is this not moving slide when I press the button? Hold on. Probably what I need to do is, okay. So just to be clear, sometimes people call these things glomus tumours. I would much rather we all just use the word paraganglioma. Glomus tumour refers to other things as well. So these little things that occur in the nail bed, which do look quite vascular and so perhaps have some similarities, are also called glomus tumours. So let's just kind of get in the correct century and call them paragangliomas. WHO would say these are tumours arising from the paraganglia, and within the head and neck, they are generally associated with parasympathetic nerves, so will not usually secrete catecholamines, but they do sometimes. You can't distinguish between the different sites based on histology, so they're basically just named by location, and classically, 4 locations in the head and neck: carotid body, vagal, jugular, and tympanic, although that doesn't quite cover the entirety of it. In our series at Guy's, we have quite a lot of these patients. So vagal paragangliomas, is debatable whether you might include them in a discussion of temporal bone paragangliomas, because obviously they do often extend into the jugular foramen, but classically they arise sort of just below it. And for the purposes of today's talk, we're going to basically concentrate on tympanic and jugular paragangliomas. It's not necessarily easy to know which tumor is which. So often tympanic and jugular tumors are confused, and jugular and vagal tumors are confused. And of course, sometimes vagal and carotid body tumors are confused, but that's outside the scope of this talk. So tympanic paragangliomas. So basically they arise within the middle ear cleft, sometimes right on the promontory, which is where you kind of, the books would lead you to expect them to arise. So sometimes you get an absolutely tiny little red dot right on the promontory. Quite often they arising slightly lower than that, so slightly more hypotympanum. It will frequently extend up towards the facial nerve, but they will not arise from the sort of attic region. Basically, they're always lower, sort of meso or hypotympanum. And the main thing that helps you say, well, this is a tympanic paraganglioma, is having a crisp, well-defined shell of bone over the jugular bulb. So they may extend down, particularly if the bulb is high, but there will be a crisp layer of bone. Jugular paragangliomas, in contrast, arise around the jugular bulb. Now, sometimes the epicenter, the sort of focus that the thing has arisen from, is on the lateral aspect of the bulb, and sometimes, probably more commonly, it's on the medial aspect of the bulb. But characteristically, on a CT, the eggshell of bone over the bulb has a sort of slightly moth-eaten appearance, with tumor sort of infiltrating the bone. And then as the tumor gets to the air-filled middle ear cleft, you get a more sort of solid bit of tumor. So that's really the key thing you're looking at. The other feature of a jugular paraganglioma is it quite frequently will have some extension within the lumen of the vein, either going back up the sigmoid sinus, or more commonly coming down the IJV into the neck. So obviously you will also hear about the term jugular tympanic tumours, which is a sort of catch-all term that people use for both groups, and that's fine, but I think it's a slightly sort of misleading term, and also the fish classification, which is the one most widely used, where they're all in one group, sort of implies that there's a sort of continuum, and that if you leave a tympanic paraganglioma, it'll turn into a jugular paraganglioma, and I think that's misleading. So, you know, I'm not very keen on that term. I think it's helpful to try and distinguish between the two, but sometimes it's not possible, particularly if a tympanic tumor has been left for a long time in a relatively new-sized bone. You know, it can be pretty hard to tell. So it's a term that is used, but perhaps not an ideal one. So distinguish between the jugular and tympanic PGL. So basically, here's some scans. I think you can see, oh, there we go. Hopefully you can see my cursor. So basically, this is tumor within the middle ear cleft, and this is the jugular bulb. Obviously, there's the carotid, and this is that sort of slightly moth-eaten appearance of the bone, perhaps more easily seen on the coronal sections. So on the other side, sort of relatively clearly defined cortex to the bone. And on the side of the tumor, well, a little bit sort of woolly looking on the CT scan. So that would alert you to the fact that you may be in for a little bit more than you were expecting if you thought that was just a straightforward tympanic tumor. Often tympanic tumors do extend down in that little niche between the jugular and the carotid and under the cochlea. So, you know, they're not necessarily straightforward to get out, even if it is a tympanic tumor, but you want to know whether the bulb's involved. If the bulb is very high, obviously it can be hard to tell. So look, on this one, you can't tell whether that little bit of bone is moth-eaten or not, because there's basically not enough of it. There's a dominant sigmoid sinus on the right-hand side and a high bulb. And so here's the tumor within the middle ear, and, you know, impossible to see. And if you get a contrast MRI, obviously the tumor enhances, but then the the jugular bulb will also enhance, so that doesn't really help. But you can, with an engaged radiologist, get some sequences that will help distinguish. So here you can see that there is tumor within the lateral aspect of the bulb in this case. So unfortunately, paragangliomas don't always follow the rules that we have set, and sometimes you get tumors that don't sort of fit that, and the epicenter is neither the middle ear nor the jugular bulb, but they're still in the temporal bone. They might be in the petrous apex, and then there's this little group, the sort of faciale tumors, where the epicenter appears to be around the facial nerve, and sort of anatomically, I don't think that should happen, but in reality it does. So when you have a tumor, a paraganglioma in a temporal bone that looks like it's sort of in the wrong place, then you need to consider the possibility that it's metastatic disease, because a metastatic paraganglioma will generally have bone mets rather than any others. But if there's nothing anywhere else, then, you know, it's probably just an ectopic primary. So here's one that presented recently, presented with a sixth nerve palsy. So diplopia on lateral gaze. With the benefit of hindsight, it probably looks relatively obvious that there are big flow voids within this tumor, but this was biopsied endoscopically, and both patient and surgeon needed some resuscitation afterwards. So that's an isolated paraganglioma, and there's no other tumors, and it's not a metastasis. She's about to have her stereotactic radiosurgery. So natural history of these tumors. And basically, the vast majority of these things are pretty indolent. So there's lots of data showing that most of them will grow maybe a fraction of a millimeter a year. That change generally well tolerated, as with anything changing slowly, people tend to adapt. And the risk of metastatic disease related to a jugular paraganglioma is extremely low. So basically, conservative management is certainly a reasonable option for a lot of these patients, and many of these tumours can be managed conservatively for many decades without anything really going wrong. However, occasionally we get one of these things that is pretty locally aggressive with deteriorating cranial nerve function, sometimes brain stem compression, sometimes everything from 6 to 12 stops working. Sometimes the patients get arteriovenous shunting. So, I mean, some of these tumours are so vascular that basically like an AVM with raised pressure, which can affect vision and cause all sorts of things to go wrong. Occasionally, you'll get metastatic disease. I think we've got 3 jugular tumours with metastases in our series. And whilst head and neck paragangliomas, in theory, are arising from the parasympathetic system, you do get catecholamine secretion sometimes, which can be significant. So how do we know whether it's one we can leave for decades or not? Well, basically, location has an impact. So the tympanic tumours tend to be pretty indolent. The main risk with a tympanic paraganglioma is a facial palsy, which is obviously a bad thing, but not perhaps lethal. And the vagal tumours tend to be the ones that cause the most trouble. That order of how likely they are to cause problems does roughly correlate with the volume that they typically present at. So it may be that actually they're all the same, but they're just bigger ones tend to present as vagal tumours that are sort of more tucked away. Anyway, mutation status has an impact. So malignancy is more associated with people with genetic predisposition. And obviously, we tend to assume that if someone presents with a big tumour and they're young, it's more likely to be a more aggressive tumour. Whereas if it's taken them until they're 70 to present, there's certainly many more decades for the tumour to have been growing for. Sort of stands to reason. So how do we work up a patient presenting with one of these things? So the first thing we do is sort of assess the whole patient. Okay, you must avoid the tendency just to focus on the tumour that you found. So we would normally get a dotatate PET. FDG PET is also fine. Dotatate is slightly more specific. And MR imaging. You need to assess whether the tumours are secreting, and urinary catecholamines is no longer an appropriate test. They should have plasma metadrenalins or plasma metanephrines, it might be called on your system. I don't know if that's a question from Prince Vade or if it's just a microphone. Anyway, so basically, yeah, so plasma mets rather than urinary catecholamines, and that should be done on everyone presenting with a paraganglioma, even if it's a tympanic paraganglioma, because they may have another tumour that's secreting. And the majority of patients will get genetic assessment and certainly take a family history. In terms of the genetics, so it's fairly common for people to have a predisposing mutation. About a third in our series, but that's a historical series going back quite a long time, and we didn't used to test everyone, and we didn't used to test for tympanic tumours, but we do now. If they have a mutation, they may well also have intra-abdominal tumours, and those are more likely to secrete and also more likely to metastasize. Family history doesn't tell you a great deal, particularly because it's hard to read because of this maternal imprinting. So the SDHD gene is the one most associated with head and neck paragangliomas, and that has maternal imprinting, so it's only expressed if you inherit it from your father. So it may therefore skip multiple generations by being passed from a mother to daughter. So basically, an absent family history isn't particularly helpful. And we also have to consider that if they do have a mutation, there may be other things going wrong other than the paragangliomas that we are interested in. There are lots of genes potentially involved. So when it comes to actually treating the disease, obviously doing nothing is an option, but doing something is also tempting. So surgery or radiation, and radiation can be in the form of a sort of conventional fractionated regime of 50 gray over 5 or 6 weeks, or a stereotactic radiosurgery type regime where you might just treat to maybe 3 fractions, or some sort of compromise halfway in between. Other options, so these things do take up isotopes, so you can use peptide therapy, typically lutetium dotatate, MIBG or octreotide are the options. But that is only used for small volume disease, so basically it's used as a treatment for metastatic disease rather than the primary tumor. And there was a period when people thought maybe serial embolization was an appropriate treatment for these tumors, but that period has ended. So when you're just trying to decide how you're going to treat it, you have to decide what it is you're trying to achieve. So most of these patients will have presented with fairly trivial symptoms. A little bit of pulsatile tinnitus would classically be the presenting symptom of a jugular paraganglioma. So surprising then to discover a great big tumor, which might require really quite major surgery if it was going to be treated surgically when they have such minor symptoms. So what are you trying to achieve with your treatment? Often they're not actually that fussed by the pulsatile tinnitus. You may say, well, we just want to prevent things getting worse, and that's reasonable, prevent disease progression, prevent cranial neuropathies. You may want to know whether they've got other tumors. Is there something secreting? Are they at risk of dropping dead from their catecholamine secretion? Or is their child or sibling at risk of dropping dead? So, those are all things we need to consider when we're managing the patient. So if the goal of your treatment is to make the tumor disappear, which is often the first thing a patient would like, then radiation doesn't work because it doesn't make the tumor disappear. In fact, it doesn't even kill it. So post-radiation, if you biopsy a tumor, you will generally still find some viable cells. However, if your definition of success is stopping the thing from progressing, then radiation works very well. You might say, well, that's only over 8 years, and these patients may have the disease for decades, but that's basically what the literature says, and the literature, as ever, doesn't really follow people up for that long. It's not clear what the impact of radiation is on the risk of metastatic disease, but that's a very low risk for these temporal bone paragangliomas. You might say, well, if the tumor is pretty indolent, why would you irradiate it? Because there are obviously clear risks associated with irradiating tumors. Actually, the data is pretty poor, but generally people might quote a figure of 1% per decade risk associated with radiation. It is clear that in youths, there are 2 factors. One is that they're likely to be alive for many more decades, so that increases the potential for them to have something wrong. But also, it seems that radiation at a younger age means the impact, the likelihood of something going wrong per decade is also higher. So it's not just that they're there for more decades, it's also that the risk of something going wrong in a given decade is slightly higher if you irradiate someone who is younger. And then, of course, there are all the other head and neck radiation problems. Again, that you might say, why would we expose someone to that when they don't have cancer? Well, depending on how we define it. But really, a lot of those are dose dependent, and the dose you would give for a paraganglioma of maybe 50 gray causes a lot less trouble than the dose you might give with an SCC of more like 60 to 70. So we don't like radiation because of the risk of long-term problems. How about an operation? Well, of course, if you can remove the whole thing and cause no problem, that's lovely. You might even be able to discharge the patient. What's not to like? But of course, surgery doesn't always go that well, and you have to warn people of a lot of risks. So we do operate on these things sometimes. There's a careful balance of the risks for the short and long term. often symptomatic control is what you're looking for, and patient choice is a factor. But often patients can be persuaded to make the right choice. So, is it possible to completely excise the jugular paraganglioma whilst preserving the middle ear and all the cranial nerves? The answer is yes, it can be done, okay? But it can only be done in the right patient with the right tumor, okay? So, you know, there are anatomical factors relating to the patient and the tumor. And even if you've got the perfect tumor in the perfect patient, there is still a long list of risks that you would have to go through. So nobody could, you know, say that they can do this reliably with absolutely no risk, which is, of course, the problem. So if you look at comparison of radiation versus surgery in the literature, this is from, well, the paper comes up in a second, it's that one, Ferlito's meta-analysis. Basically, whilst you might intuitively say removing the tumor has got to be better in terms of long-term control than treating with radiotherapy, the answer is the literature doesn't support that, because often it's hard to know that you've removed all of the tumor, particularly if you're trying to avoid imposing cranial neuropathies. So tumor control, less good with surgery than radiotherapy. Major complications, much less good, and even looking at the p-values, with surgery than radiotherapy. And cranial nerve palsies, much more frequent with surgery than radiotherapy. So whilst, I mean, that is sort of an average. A lot of those aren't the right patient and they aren't the right tumor. And maybe that's why people have operated on them and got poor results. But on average, you're better off treating it with radiotherapy. There's the paper. So who should receive treatment? So the default nowadays is for a jugular paraganglioma to be treated with radiation. That is the sort of standard practice. That may be after a period of initial observation. Often patients are not very keen on sitting there letting this scary thing grow. And so often they basically say, look, I either want it out or I want to treat with radiation now. Radiation does reduce the vascularity of the tumor, and their pulsatile often does get better with it. And it can be in the form of stereotactic radiosurgery for the smaller tumors or a fractionated regime for the larger tumors. If we look at the history of surgery, or if you're looking at surgery, you've got to decide what it is that you're actually trying to do. What are we talking about when we talk about surgery for, this is a nerve being transposed to one side to distract you. If we're talking about symptomatic relief, or are we talking about trying to cure the patient of their tumor by removing the whole thing? Are we looking at single stage surgery or staged procedure? Can we preserve the middle ear? Does the facial nerve need transposing? These are all sort of variables. There's no right answer for those things. But basically, the surgery has evolved. So it used to be the case that someone would be diagnosed with one of these things, and they'd come to the clinic and they'd be told, well, look, I'm terribly sorry, but you've got this awful tumor in your head which will kill you. And luckily, you've come to see this heroic surgeon who will remove it and save your life, but at a significant price. And the advice was that as long as you counsel the patient appropriately, i.e. scare the whatever out of them, then they will be grateful even if they do have some morbidity following surgery. So you would classically do blind set closure, total petrosectomy, transpose the facial nerve, and remove the whole of the tumor, or at least everything you could in the sea of blood. And then people started saying, oh, well, maybe we can preserve lower cranial nerve function by preserving the medial wall of the jugular bulb and the pars nervosa. And maybe we can preserve the middle ear in some patients, or just transpose the nerve a little bit. And if there's a bit left, we can irradiate it. Now, this little video on the right, so this is the jugular bulb being opened. This is tumor, sort of a little finger of tumor that was in the bulb. But what you see here is the medial wall, and then a whole load of tumor medial to the medial wall. So the majority of these tumors, the bulk of the volume is actually medial to the medial wall of the jugular bulb. So the idea that you preserve the medial wall of the bulb, you stop having sort of lopped off the finger of tumor that was extending into the lumen, and call it a day, is sort of appealing in a way. Your risk of imposing a lower cranial nerve palsy is extremely low, but you have put the patient through a rather large operation and left a big lump of the original tumor there, which will normally grow. In contrast to a schwannoma, where often you can leave a relatively big lump and it doesn't grow, these ones normally will. So they're likely to end up having a full course of radiation anyway. The same, in fact, radiation they would have had if you'd just done that without having put them through the ordeal of surgery. So basically, what's the point? We would now say primary radiotherapy is likely to be the way forward. You might want to do a small operation to address some symptoms that they have. So, and these are the symptoms that they might have that you can't address without an operation. That said, young patients with favorable tumors, so if they're young and they've got one of those tumors where you think, well, I can get this all out without causing any harm, then I think you can certainly give them the choice. The other issue is if they have a lot of catecholamine secretion and they're young, there's an issue there, because in the long term, that has significant risk associated with it. So here's an example of a 30-year-old, relatively mild symptoms considering her tumor, but normal adrenaline 22,000, so 20 times the upper limit of normal. Initially told that the tumor was unresectable. So this is her pre-op scan. So, big CPA component, big flow voids all around it, and extending down into the jugular foramen, all basically looking a little bit intimidating. We felt surgery was appropriate because of the secretion. So she had appropriate blockade, embolisation, and the intracranial component removed as a first stage, and that was just before Christmas. Unfortunately, second stage delayed by COVID, but the facial palsy that I will confess that she had after the first stage has recovered, and she's compensated for her lower cranial nerves, and we'll take out the rest. And I think, in that case, it's justifiable, but it's often not. Here's another one where you might say, well, really, is surgery better than radiotherapy? This is the finger of tumor extending down the IJV, and it's grown gradually down from the skull base and is on the verge of entering the chest. So perhaps a little opening of the IJV and just pulling that finger out might be better than irradiating the whole of her neck. For younger people, I'm afraid, there's a lot of wariness about radiotherapy, but it's still better than doing a big operation and then irradiating them. So I still think that as a primary treatment, it probably is the way forward, unless they happen to have one of those very favorable tumors. Now, I realize we're running out of time, so tympanic paragangliomas are much more straightforward. Basically, they should be removed in contrast to the jugulars. You can see why I don't like them all being put in one box, because a tympanic is a completely different thing. It should be removed because it can be removed with minimal risk, okay? And there's no role for conservative management, because the first thing that goes wrong after the pulsatile tinnitus is a facial palsy. And it's very frustrating to be sent a patient with a facial palsy from their tympanic paraganglioma that has been watched for years until it went wrong. So basically, tympanic paragangliomas should be removed at presentation, unless, of course, the patient is old and infirm. And of course, they should still be worked up, because you don't want them to arrest on the table while they're having a tympanic paraganglioma removed because you didn't notice that they had a pheo as well. Who should be doing that surgery? Well, it's not like normal middle ear surgery. There's an awful lot more blood involved. You do need a wide approach. It's often nestled between the carotid and jugular bulb. So basically, it's probably generally something that a skull-based otologist is going to be happier doing than a regular one. And it's not, a cat is not generally the way forward. You just basically need to drop the floor of the ear canal to approach the thing. I think we'll skip this because we're a little bit behind. Here is a lovely scan. This woman had a tympanicum that I removed. Obviously, she had some other tumors as well. And some of the patients presenting with multiple tumors will present and then you never find another one. Others just keep popping up tumors every year or two. So, you know, there's an ongoing process. You don't sort of take out one and then discharge them. So I guess the message is surgery is not always the answer. The things are complicated. We have a neuroendocrine MDT where these cases get discussed. And we have lovely British Skull-Based Society consensus document on how these things should be managed, which is now available at least online. So, the end.
Thank you very much, Rupert. That was a really good overview and a really good sort of pragmatic approach for managing them. We haven't got a lot of time, but just a couple of questions. One interesting one. So does radiotherapy reduce catecholamine production?
Well, yes, it does, very slowly. So I think over subsequent years, you do tend to see a reduction, but you know, I think if the levels were only slightly high or in an older patient, you might be happy with that. The thing is that normally if there's a secretion tumor, it's not slightly elevating the catecholamine levels. It's kind of absolutely knocking them out of the ballpark. So,
okay, and then just one other question. The role of embolisation in the modern...
Preoperatively for, I would embolize jugular and vagal paragangliomas preoperatively. Tympanic's basically too small. They won't do it, even if you ask them to, which I don't think the risk would be appropriate. And corrosive body tumors, I don't embolize, but certainly there's no way you want to take out a jugular paraganglioma without it having been embolized preoperatively, particularly if there's an intradural component, you know, that would be just foolhardy.
Yeah, great. Okay, fantastic. Thank you very much, Rupert. That was great.